Anji.
I think Shamsul is disconnected because his
he's on the road now.
Yeah.
Shamsul needs to get a
make me co-host. Make me co-host. I need to record now.
MG Hector.
Exactly, sir.
वो गाड़ी है ना Internet Inside.
Internet Inside. वो चाहिए sir.
Okay, sir. So we'll go live in 5, 4, 3, 2, 1. So welcome everybody, and we are live. We can go ahead.
Good evening, everybody. So we welcome our President, Sir, Dr. Shivashankar, sir, our Secretary, Dr. Naveen, sir, and we are having our second webinar of the IOA subcommittee of the Ilizarov. This time we have decided to do a webinar on Ilizarov hip reconstruction. It's very important to deal with some complex situations around hip. So we tried to make this webinar interesting by having our foreign faculty as Professor Gamal Hosny. We are really honored to have you, sir. So it will be really interesting to have his experience on the Ilizarov hip reconstruction. And we have from the national faculty, we have Dr. Ruta Kulkarni, who is also our president of the ASAMI, and we have Dr. Mangal Parihar. So he is the renowned Ilizarov surgeon of our country, and we'll be speaking on this Ilizarov hip reconstruction. We'll concentrate mostly on the Ilizarov hip reconstruction. May I request our president, sir, Dr. Shivashankar, sir, to have a word, and thereafter may we have a word from Professor Naveen, sir, and thereafter I would like Dr. Ravi Chauhan, who is our secretary, to introduce the foreign speaker, foreign faculty, Professor Gamal Hosny. Over to you, Shivashankar, sir.
Thank you very much, Dr. Altaf Kawoosa, the chairman for the Ilizarov subcommittee of IOA. This is the second meeting we are having under this subcommittee. I thank you for actively getting involved and spreading the knowledge of Ilizarov through these webinars through IOA. I would also like to thank Dr. Ruta Kulkarni, President of ASAMI India, and Dr. Ravi Chauhan, Secretary, and other people involved in the spreading of knowledge of Ilizarov, like our Shamsul, Hoda, and Dr. Mangal Parihar, for taking efforts to be a part of this panel. I would extend my warm welcome to the foreign faculty, Dr. Gamal Hosny, who will be sharing his vast experience in Ilizarov hip reconstruction surgeries. Without wasting much time, I hand over the mic now to our IOA Secretary, Dr. Naveen Thakkar, to say a few words before the proceedings start. Thank you very much.
Hello. Good evening to everybody. We welcome you all on behalf of the IOA office. And there is a good coordination in all the committee, and this ASAMI is working very hard for fantastic scientific program, and we have legends today for hip reconstruction surgery. So without wasting any time, let us start the academic part soon. Thank you very much.
Dr. Ravi, you are muted.
Thank you, everyone. Well, good evening. So today our eminent speakers are Dr. Gamal Hosny from Cairo, Egypt, Dr. Mangal Parihar, he is the EC member of ASAMI India, Dr. Ruta Kulkarni, he is our president of ASAMI India, Dr. Altaf Kawoosa, he is the chairman of Ilizarov subcommittee, IOA. So our first speaker and the keynote speaker, Dr. Gamal Ahmed Hosny. He is the professor of orthopedic surgery, Bana University Hospitals, Egypt. He is the chairman of the permanent committee for the academic promotion in the Egyptian universities. He is the specialty editor of Journal of Pediatric Orthopedics, Bana. He is the co-chairman of Pediatric Orthopedic Subspecialty of SICOT. He is the past president of ASAMI International, president of Egyptian Orthopedic Association. Dr. Hosny was born in Cairo and graduated from Bana University. He then traveled abroad to work in many centers in Europe, where he undertook several fellowships in Vienna, Austria, in Belgium, in England. He developed the Al Haram Center, which belongs to the public service sector, to treat poor patients requiring bone lengthening and deformity corrections for free. He was the chairman of this center for about 10 years, from 1996 to 2006, at which time more than 2,000 handicapped patients were treated. He is well known for being a great proponent of the principles of equity of healthcare and the right of every human being to receive the best type of treatment. Over the years, he has also trained many young surgeons from Egypt as well as Africa, the Arab countries, and the Middle East. He has been working in the field of limb lengthening, reconstruction, deformity correction, and pediatric orthopedics for over 35 years. Over the years, he has delivered more than 500 national and international presentations and is the author and co-author of more than 100 articles or textbook chapters. He is also a reviewer and an editor of many peer-reviewed international journals. His major research interests include congenital deformities, non-union, pediatric orthopedics, and deformity planning. Dr. Hosny has been an invited speaker and a scientific committee member of many meetings organized by international orthopedic societies such as SICOT, ASAMI British, ASAMI Germany, India, British Limb Lengthening Reconstruction Society, American LLRS, and many others. Furthermore, he has organized several education courses, seminars, and conferences around the world. Dr. Hosny has developed many innovations during the past 2 decades, such as a new method of ultrasonography for early diagnosis of hip dysplasia and the treatment of major limb length deficiencies without amputation, new classification of PFFD, and bone lengthening. His ideas have been adopted by many orthopedic surgeons throughout the world. Welcome, sir. Our next speaker is Dr. Mangal Parihar. After completing his MBBS, he did his MS from St. GS Medical College, Mumbai, Maharashtra. He has served as a faculty in St. GS Medical College, thereafter over to UK and US for further training. He did his fellowship in Ilizarov and deformity correction under Dr. Dror Pele at International Center for Limb Lengthening and Reconstruction, USA. He also did his fellowship in joint replacement surgery under Dr. C.S. Ranawat. His work in the field of deformity correction and reconstructive orthopedic surgery is unparalleled, with an experience of more than 16 years at Center of Limb Lengthening and Reconstruction, Mumbai. He is attached to Sir H.N. Hospital, Fortis Hospital, Police Hospital, Mumbai. He is the Honorary Associate Professor at Grant Medical College and Sir J.J. Hospital, Mumbai. He has conducted more than 60 workshops all across the nation and abroad for treating Ilizarov methods. He has delivered numerous lectures at various national and international platforms. He has been pioneered the use of 6-axis correction systems used for the complex trauma and deformities. He has devised and popularized the fixator-assisted STO as well as intra-articular osteotomy for malunited proximal tibia fractures. He is the founder of internet group India Orth, which is one of the oldest groups for internet. Our next speaker is Dr. Ruta Kulkarni. He is our president of ASAMI India. She is the former vice president of ASAMI India. She is also the advisor of IOA Ilizarov committee. She is currently the professor of orthopedics and head of the department of pediatric orthopedics at Swasthi Yog Pratishthan, Miraj, Maharashtra. She has delivered lectures on Ilizarov and pediatric orthopedics at various national and international platforms. She has chaired numerous sessions at various national and international conferences of repute. She has numerous publications in various national and international journals. She has conducted many workshops in Ilizarov and deformity correction. Her field of interest is deformity correction and limb lengthening. Welcome, ma'am. Our next speaker is Dr. Altaf Kawoosa. He is the current chairman of Ilizarov Subcommittee of Indian Orthopaedic Association. He is currently the professor of orthopedics at GMC Srinagar, Jammu and Kashmir. He is also the EC member of ASAMI India. He has 3 years of experience with Ilizarov technique. He has more than 60 publications, lot of awards like Best Outgoing Graduate of MBBS, Young Scientist Award, DAK Merit Award, 2 Best Paper Awards in SKIMS and Zoocon. He has conducted a lot of workshops, to name a few. He was the course director at ASAMICon 2020 PGI deformity course in 2018 and 19. Innovations, he has developed 2 new techniques for Keen box disease and neglected Montegia fracture dislocation. Welcome, Altaaf sir. So now, without wasting time, I am handing over to our first speaker, Dr. Gamal Hosny. Sir, over to you. Please share your slides.
Thank you so much. First of all, good evening, everybody. And I would like to thank the Indian Orthopaedic Association for inviting me for such a prestigious event. I would like to thank Dr. Altaaf Ahmed for inviting me, the president, and of course, we are all, I know all of you, we've met before many times in the meetings. And it's a pleasure for me to participate in this meeting and to learn from you. I know that you all have great experience. And I'm going to speak about Ilizarov around the hip in general, and I will concentrate on the pelvic support osteotomy. If we think Ilizarov the hip, we have to think about traumatic conditions and non-traumatic conditions. Most of the people, they ignore the traumatic conditions, but this is not true. We have many indications for Ilizarov around the hip, for Ilizarov methods. Sometimes you have open fractures and polytrauma patients. As you see here, a trochanteric fracture with another fracture and another comminuted fracture in the distal femur. Infected fractures. The patient had been treated by open reduction and internal fixation and many debridement, but you know, this is after 1 month with severe infection. Osteoporotic fractures. This is an external fixator and have an osteoporotic fracture with mild trauma. Firearm injury in the proximal femur. Infected non-union, you see here, infected non-union in the frame. The first thing that I want to talk about the closed reduction techniques. This is the real merit of Ilizarov around the hip. It's not just the fixation. There are many methods to do closed reduction without any incision. You know, the classic treatment of proximal femoral fracture is open reduction and internal fixation. Any open reduction means soft tissue interruption. So that means you add injury to the injury. But the real advantage of Ilizarov method that you can do 100% closed reduction of fractures. Like this treatment. And if you talk about closed reduction of fractures, it's exactly swimming against the current because everybody speaks about open reduction and internal fixation. In this case, as you see here, this is in the operating theater. We use multiple wire technique, multiple serrated wire technique, and the cannulated half pin, and this is the end picture. Again, if you have an osteoporotic fracture, people insist on having an intramedullary something to correct the intra to the osteoporotic fracture. But look here to this osteoporotic fracture. We use the multiple wire techniques and compression. You see here the multiple wire technique, and we compress the fracture. See here, and again, union. Infected fracture. If you have failure of internal fixation and failure of open reduction, we do closed reduction. It's totally the opposite. You know, people always think about if you have failure of closed reduction, you have to do open reduction and internal fixation. But we don't think so. If you have failure of open reduction, we do closed reduction, like this patient. This is failure of open reduction and internal fixation, and we did closed reduction and external fixation by Ilizarov. Infected non-union of the proximal femur, like this patient, who had been treated by external fixator again, and severe infection. And this is after 6 months of treatment, non-union, severe infection. We removed the frame and we put the frame of the proximal femur, look here to the proximal femur, and we did corticotomy of the distal femur. Now this is the closed reduction techniques. In the outpatient clinic, we start gradual distraction of the proximal fracture. This is gradual after 3 weeks, after 4 weeks, and the gradual distraction of the corticotomy side. Then after we reached the length, we did side-to-side compression, 1 millimeter per day. So you can reduce the fracture, close treatment of fracture in the operating theater and post-operatively without anesthesia or analgesia. And you see here at the end, the length and complete union. Now talking about the non-traumatic conditions, we'll talk about arthrodiastasis and osteotomy. There are many indications for Ilizarov methods. And look to the arthrodiastasis, Perthes disease, avascular necrosis, osteoarthritis, chondrolysis, neglected hip dislocation, unstable capital femoral epiphysis, adolescent arthritic hip. And this is an example. Interlocking or intramedullary nail ended up with avascular necrosis. We removed it and we did over distraction, and this is afterwards. Perthes disease, 12 years old boy, and this extruded segment, you see here. And people were thinking about salvage procedures. We don't think so. You see the picture with the extruded segment. We did arthrodiastasis before and after. And you see during the follow-up, you see how the patient running, see? I can squat. Squatting is important in these areas. Proximal femoral focal deficiency. It's a very important tool in proximal femoral focal deficiency. Like this picture was bilateral type. This is type 3 in my classification. We have apparent neck pseudoarthrosis. It's not real pseudoarthrosis. And you see the picture with 3D picture. You see the angulation here. We did distraction histogenesis for the apparent pseudoarthrosis, gradual distraction, and the correction of the deformity. You see the gradual distraction and bone formation. And this is after removal. And the second stage, we did lengthening, corticotomy up there, and the corrected deformity. It's something like pelvic support, up high pelvic support, and lengthening, you see. You see the picture. Cases treated before failure of, this is failure of super hip procedure, the so-called super hip, which ended up with total stiffness of the hip and 70 degrees flexion and no abduction. And this is the picture. He had super hip and varus osteotomy. Now we do arthrodiastasis and the gradual correction of the hip flexion deformity between the proximal femur and the acetabulum. And at the same time, we did lengthening. And at the same time, we corrected the flexed knee. You see here the picture. This is my first pelvic support. In such patients, high osteotomy. The people claim that high osteotomy can cause problems. But this is not true. I didn't find it in the literature. There is no proof. And lengthening. And this is after 15 years follow-up. You see this patient. The way she runs. And squatting. And this is my recent publications about pelvic support osteotomy. 2000, 21, 21, and 2020. Why I'm going to talk about my experience with pelvic support osteotomy. Unfortunately, the most famous chapter in the book talking about pelvic support osteotomy coming from a place, they have only publication about 8 cases done by 6 authors over 10 years period. That means each author, his experience is something like 0.2 patient per year or 0.1 patient per year. And they wrote something like 23 pages about the rules and rules of the rules. But why on earth the people, they don't think about the surgical load? When you talk about arthroplasty, the people, they always ask you about your surgical load. How many cases you do per year or something before giving us your tips and tricks of the operation. But why in our field, the people, they give their tips and tricks, especially in the West, with doing a very small number of patients? Think about the number of patients in India, number of patients in China, number of patients in Egypt. We have huge number of patients. But they always talk us about the rules and the rules of the rules, and they have very few number of patients. And you look to their presentation, they always talk about they have the largest experience on the world, which is not true. It's not true at all. Anyhow, my humbled experience, I've done 33 cases to 2007. Then I have the average 9 cases each year. So I've done more than 150 cases. I published the first 160 cases with long-term follow-up. And this is the pelvic support. You all know it. Osteotomy and displacement of the proximal segment. The first subtrochanteric valgus osteotomy was done maybe more than 180 years ago. It's not a new operation. And all those people, they talk about it. Ilizarov popularized the idea by adding another osteotomy and the correction of the mechanical axis and to lengthening at the same time. Many people consider it as a salvage procedure in cases with severe hip joint destruction. This is an example of my indications. Old septic arthritis. This is 36 years old man, heavy worker. This patient, and you see the upward migration of the trochanter. Congenital short femur, like this patient. The patient has no acetabulum, you see, very shallow. Neglected fracture neck femur. This patient comes after 2 years, 3 years, and 4 years. When the people talk about neglected fracture neck femur, they talk about neglected fracture 5 days or 6 days. But I'm talking about 4 years, 5 years neglected fracture neck femur. Neglected DDH at the age 26. Again, failure of treatment of DDH. This patient had 5 previous operations. A migrating upper femur. This plastic hip, again. AVN, after safe surgical dislocation. They always say safe surgical dislocation. I don't think that the term safe can be applied to any surgery. You always have problems and you have precautions or something like this. So this is after safe surgical dislocation, avascular necrosis. Osteoarthritis in dying age. You see here, severe osteoarthritis with flexion and abduction and osteoarthritis. Failure of hip arthroplasty. You see the fat patient and failure of 2 previous hip arthroplasty and infection. Are you going to do more with this weight? Revision of pelvic support osteotomy. This patient had pelvic support osteotomy 10 years ago when he was young. And you see remodeling of the upper femur, and we did revision of the pelvic support. Preoperative planning. I will just show you the way I do it, pelvic support osteotomy. We have a long film at first. Then the patient has to meet 2 previous cases treated with pelvic support. Also, he has to visit an arthroplasty surgeon who is used to do arthroplasty in the young age, like this patient. And I will show you this patient. And I had pelvic support on one side. And when she got older at age 13, and we had a follow-up for 21 years. And then she went to have an arthroplasty on the other side. She chose for herself. Her family, when she was young, they chose the pelvic support. When she got older, she chose the total hip on the other side. The operative technique, again, we depend upon deeds and no words. You can think about players and versus spectators. Unfortunately, in the English literature coming from the States and Europe, they did a very small number of cases and they have very limited indications. Why? Because in this condition, they usually have arthroplasty even in the younger age. And you know, this case which had arthroplasty on one side and pelvic support, the reviewers sent me their comment saying that we think that if this case presented to you now, I'm sure that you should have done pelvic total hip on both sides, even in the age 13. So I wonder why in the West they decided to give us their scheme or the operative principles and the tips and tricks of doing pelvic support, while actually their experience is nothing in pelvic support osteotomy. You can do unilateral fixator in the upper femur. I've seen that before, but I've never did that. You can do plate. But remember, if you do a plate, you cannot change the angle of the proximal femur. But if you use Ilizarov on the proximal femur, you can change the angle after 1 week, after 2 months even. With your calculations, you can change the angle in your outpatient clinic, 1 millimeter per day. The frame, we divide the frame into 3 levels. The first in the upper femur, the second in the middle, and we do another ring in the distal part. The patient in the supine position, in ordinary reducing table, we don't use fracture table. We do adduction, and usually they said that the angle, you have to choose the angle depending upon this maneuver by putting in adduction. But remember, the patient in flexion, adduction, so it's not accurate. So when you do this, this is the contact point. They usually say that in this contact point, you have to do your osteotomy. This is not true. If you do this osteotomy, you will find the osteotomy very low. So my osteotomy site has to be about 1.5 to 2 centimeters above the real contact point. Because there's illusion. Because you have flexion and you do adduction, so this is not a real contact point. Again, you apply your frame in the upper femur this way by 2 or 3 half pins. Usually I put at least 3 half pins. And I start the surgical approach before applying the middle part, fixation of the middle part. Why? When you put them in many times, you have small spaces. So you have to do your approach here and you do multiple drill holes, but don't do the osteotomy. Then we apply the frame in the proximal part, and then we complete the osteotomy. Just put your osteotome and you do closed just osteotomy. So you don't do the approach, and you connect the arches and you correct. From this part, you can correct all the deformities. And this is an example, the first wire, and you put the half pins in the same direction. You see here. Then another one vertical to the bone. And this is the site of the osteotomy above the area of contact. And then you move the middle. And then remember that you have flexion deformity. You can do adduction, extension, and derotation from the proximal osteotomy site. And many times you have deformities, you have rotational deformities external or internal deformity. So you can correct the rotational deformity from the proximal femur. The level of support, it can be high support and low support. I don't know, again, they claim that it has to be a low support. This is not true. There was no proof at all. I've done many high support, and this is an example. The patient can squat, no pain, no problem. So if you have a working angle, if you have a very high upper femur, you can use the low support. You don't have to waste all this part to do low support. And don't listen to them. You don't have a proof. Again, this is the low support. You see, this is the site of the osteotomy. You see the site, and this is high support. And then you do medialization. Then you do your corticotomy in the upper femur. A second trick, over lengthening. I was before just doing lengthening. When the two knees in the same level, I stopped. But I found that there is some limping afterwards. Remember, this part is not fixed. So you have telescoping. So I started to do over lengthening, 1.5 centimeter lengthening here. And after this, I have far better gait. So I do over lengthening 1.5 centimeters. So over lengthening is very important. The problems we meet, if you do it in the young age, but you have to do it because there's upward migration of the upper femur, and there's no limit. So we did this osteotomy, you see the angle. You see the improvement of the angle because the body treats this angle as a deformity and corrected naturally. So this is after 4 years. It's almost, there is no limb length inequality, but there is no angle here and you have to revise it. DVT. I have also an instance of DVT. You have to remember, it looks like any hip operation. Remember that DVT is there. And this patient is thin, very active, but he had DVT. So you have to give DVT prophylaxis when indicated. It's important. And this patient, look at this patient, you see, she came to me at age 13. And we sent her to the arthroplasty surgeon. She had 5 previous operations. And the family chose pelvic support osteotomy on the left side. And you see after the support, with the long follow-up, see the gait. And then this is, after 7 years, she started to develop arthritis. And then she had severe pain. And after 14 years, she had the arthroplasty on the other side. Because again, we sent her to the arthroplasty surgeon, but she chose hip arthroplasty. And you had 21 years follow-up for the left hip and 7 years for the arthroplasty. And look now to at the end of the follow-up. And she had 2 children. 21 years follow-up of the pelvic support on the left side and 7 years follow-up of the total hip on the right-hand side. She had a high heel, you see this, about 10 centimeters high heel. We asked her to squat. Just I want to invite everybody to participate in the MIPOS meeting, Middle East Pediatric Orthopaedic Society, in collaboration with the Egyptian Orthopaedic Association, from 14 to 16 October, next October, hybrid meeting. And this is the form for abstract submission. Please, I need many of my Indian friends. I know that you all have thousands of problems in pediatric orthopedics. And please send me your vision. In conclusion, Ilizarov method is effective in treating many traumatic and post-traumatic conditions around the hip. The real merit of the use of the circular fixator as a definitive treatment is closed operative treatment to fractures. Gradual post-operative reduction during follow-up is also possible without anesthesia or analgesia. Long and the mid-term results of Ilizarov modification of pelvic support are encouraging. Remember, perhaps we're talking about the turtle and the rabbit, but I prefer the turtle. It's safe, slow, but you have surely better results. Thank you.
Thank you, Professor Gamal, for a wonderful presentation. You highlighted the role of Ilizarov in diverse conditions around hip, ranging from non-unions to these deformities, and then proximal focal femoral deficiencies and pelvic support osteotomy. It was really wonderful to listen to your lecture. Maybe there may be many questions, and then I think there will be some questions which will be common to all presentations. So with the permission of the president, I think, and with the permission of the panelists, I think that we have a couple of questions right now. And on that, we will have a preference from, if we have any questions from the viewers, Dr. Shamsul may let us know. If we don't have them, then maybe a small couple of questions from the panel, and then we'll go for another presentation. Because personally, I feel I have many questions myself, but I think once we are done with our presentations, many of the questions might go off. And then finally, we might be left with certain confusions or certain things which we'd like to know from you. So maybe we have it at the end. For just one question, I would like to ask you that I saw your all presentations that there are a lot of metal and a lot of rings and wires and pins. What is in a nutshell, the acceptability of the frames in your population? Will they have? Because at an average, a pelvic support osteotomy, in my experience, would take 8 to 9 months for consolidation, limb length equalization. So what about their acceptability? And that too, especially around hip, which would need it's kind of a difficult position around hip. Do your patients complain about that?
Perhaps in the beginning, in the first few years. But now most of the people are coming to have Ilizarov method. And before we do the operation, I will let them stay, just even if the patient insisted to have the operation, I let him, stay and see other people having the frame or something like this before the operation. And we give them the choice. If they need this, if they want to have this procedure, or if they have another procedure. Most of the people, they choose it. The idea that Ilizarov is cumbersome, causing psychological problems or something, especially in trauma, comes from the Western world. And I always joke about this when I talk to them, because I told them, if you have a patient with polytrauma and comatose, how did you know that the patient says this is cumbersome and will cause psychological problems? The patient is comatose. So how you guess this? So if the patient knows everything about the situation, and there are many indications, you don't have other option or limited options. And
right.
Actually, I don't have real problem with my patients when I talk to them. And I can hardly say that most of them, they choose the way I choose, except this patient with arthroplasty.
That's right, sir. Because
I failed to convince her this time.
Yeah, because we also see that once, like your patients you showed in many conditions, like once everything fails, it's the only rescue is with Ilizarov.
Yes,
so
exactly.
Naturally, sometimes patients don't have any choice, and the end result is always great. So with these words, I think, do we have any questions from the panel?
Can I ask one?
Yeah, please.
First of all, thank you, Professor, for an excellent overview. I just wanted to ask about the last case which you showed, the girl who had pelvic support on one side and arthroplasty on the other side. So what is her opinion now? Is she happy with the pelvic support, or she repents to have undergone pelvic support and thinks that I should have undergone arthroplasty?
This is a very important question.
Yeah.
For this case, you have 21 years follow-up for the pelvic support and 7 years for the arthroplasty. The patient, this case report was published in the Bone and Joint 2 months ago, and they asked about the clinical picture and the range of motion and the video clips, the way she moves. And the examination was done by the arthroplasty surgeon. And he reported that the range of motion with the pelvic support was better than the range of motion with the hip arthroplasty. And there was no pain, and there was no complaint. And the method is, some people think that pelvic support was designed to postpone the need for arthroplasty. This is not true. It's done, the pelvic support was done for good. That means if you do pelvic support, it's a single operation for life. You don't need a hip arthroplasty. And this was the proof by this patient. I hope I answered the question.
Yeah, thanks. Thank you, sir.
Sure.
So I think may we go towards the next lecture by Dr. Ruta Kulkarni.
Yeah.
We'll be also speaking about her experience with Ilizarov hip reconstruction. Dr. Ruta.
Okay, so I'll share my screen. So thank you, Professor Hosny, for giving an excellent overview of use of Ilizarov in complex hip problems. I'm going to talk about Ilizarov hip reconstruction. And the main indication in my cases is old infantile septic arthritis, where the capital femoral epiphysis is almost completely destroyed. But I have done Ilizarov hip reconstruction in few other indications like tuberculosis of hip and idiopathic chondrolysis. So I have done this procedure in the age range of 12 to 16. All the patients who had old infantile septic hip had bad Trendelenburg lurch and telescoping. They had shortening and they had instability. So the rationale of doing Ilizarov hip reconstruction was to give them some stability by reducing, if not eliminating, by reducing the Trendelenburg lurch, Trendelenburg gait, by doing an extreme valgus osteotomy and tensioning the abductors. This procedure also equalizes the leg length, corrects the hyperlordosis, and most important, it preserves the movements of the hip, giving fair amount of stability to the hip. So Ilizarov hip reconstruction is done with two osteotomies. The proximal osteotomy is a valgus osteotomy for pelvic support. We do it at the level of ischial tuberosity. This planning is given by Dr. Robert Paley in his book. So I do it according to his instructions. So I do it at the level of ischial tuberosity. In the proximal osteotomy, we do valgus. We also translate the distal fragment medially. We also do a little amount of extension, about 5 to 10 degrees of extension to lock the joint during weight bearing. And usually extreme valgus causes a lot of external rotation. So we have to rotate internally at the proximal osteotomy. The distal osteotomy is used for lengthening and correction of knee valgus. So this is the planning. For planning, if the patient can stand on the affected site, we take a monopodal stance X-ray, or in supine position, we take an X-ray in maximum amount of adduction. So we calculate the maximum possible adduction and then add 15-degree overcorrection to it. So in the maximum adducted position, the level of femur at the ischial tuberosity is the level of proximal osteotomy. So how do we plan the distal osteotomy? We have to do a paper drawing. In the paper drawing, we hold the proximal osteotomy in maximum angle, as I've already told you in the slide before this. So we hold the osteotomy, proximal osteotomy in maximum valgus, and then we draw this red line, which is the mechanical axis of proximal fragment. So this is perpendicular to this pelvis line, this red line, and it passes through the apex of the proximal osteotomy. The distal axis is the mechanical axis of tibia, which is extended proximally. So the intersection of these two axes gives us the site of distal osteotomy. So this is how we plan for the distal osteotomy. Then we lengthen at the distal osteotomy, and at the end of lengthening, we correct the valgus by turning it into varus. So then this is the final mechanical axis, which is perpendicular to the pelvis line. So this is a small animation. You can see this is the maximum amount of adduction we find out. In this case, it is 30 degrees. And in this position, we find out the level of osteotomy. So it's at the level of ischial tuberosity. So we have to add 15 degrees to it and then angle it into valgus like that. We also do medial translation, internal rotation, and a little amount of extension here at the proximal corticotomy side. Then we plan for the distal osteotomy, as I've already told you. We lengthen in this position, and finally we turn it into varus. So old infantile septic hip, as I've already told you, is the commonest indication for doing pelvic support. So this girl came to me at the age of 16 years. She had infantile septic hip, and look at the overriding of the femur. It was very high. And there was very bad telescoping. There was a lot of instability and shortening. So this is the X-ray maximum adduction. I added 15 degrees to it and did the proximal osteotomy. You can see I've already translated medially and rotated. And that's the distal osteotomy. At the end of lengthening, I turn it into varus. So this is the final X-ray. That's the final orthoradiogram. This is 2-year follow-up actually. And this is 2-year follow-up showing full function. And this is the Trendelenburg test actually. Though the Trendelenburg lurch is not completely gone, it's reduced remarkably. And you can see she can stand very comfortably on the affected leg. Previously, before surgery, this was impossible and there was severe telescoping and instability. So coming to idiopathic chondrolysis, this 12-year-old girl had idiopathic chondrolysis, and very commonly it is done. She was treated as tuberculosis. She had received anti-tuberculous drugs for 1 full year, but there was no relief of symptoms. Her pain persisted. She had very bad arthritic hip. So I removed her head and did a pelvic support osteotomy. That's her orthoradiogram. And that's her function. And see, the Trendelenburg test completely disappeared. She was very happy with the surgery. Tuberculosis of hip. Again, this 12-year-old boy had tuberculosis of hip, and there was complete destruction of the head and severe arthritic changes in the joint. It was very painful hip. So I removed the head and then did a pelvic support osteotomy. And as you can see here, I lengthen it in valgus position. And once the lengthening is over, I turn it into varus. So this is the final X-ray, and limb length discrepancy is also completely corrected. This was his Trendelenburg test. So I had my shares of complications like knee stiffness and reduced hip flexion. But both these things were correctable with physiotherapy. With good physiotherapy, actually, I gained back both the movements in knee and hip both. Then pain and some intolerance for the bulky fixator was there. The residual shortening and residual Trendelenburg lurch were again one of the complications. As Professor Hosny has pointed out that we should always over lengthen, and I completely agree with him, because in spite of correcting the limb length discrepancy, once the patient started walking and after some years, there was some residual shortening because there was some migration of the osteotomy. So I think over lengthening is a good idea. So to conclude, I can say that Ilizarov hip reconstruction worked quite well in the age range of this 12 to 16. There was good improvement in the stability of the hip, and most importantly, movements of the hip were preserved, and the gait of these patients improved significantly. Thank you for your kind attention.
Thank you, Dr. Ruta, for a nice presentation. You really highlighted the methods of actually doing the pelvic support osteotomy and then realignment osteotomy and limb length equalization. Like you said, you agreed with Professor Gamal that you would be over lengthening, but I had a different take on that. I would like to kind of monitor it, because to me, the knee stiffness and reducing range of motion around knee is equally important, as well as getting the length, actual length. Because at the end of the day, everybody would experience that there's some kind of a loss of knee range of motion around knee. So in my cases, I prefer to kind of monitor, I think modulate in such a way that I get adequate range of motion around knee as well as good amount of length. So maybe I a little bit differ from that you would go towards some kind of a limb later. But at the same time, we have to weigh against getting any stiffness around the knee. And second thing is that I pointed out in one of your cases that you had done osteotomy distal, and there's some kind of a procurvatum induced in this. That's why I think corticotomy, little proximal, I think to my knowledge is a little more helpful rather than going to distal, because it ends up in some kind of a stiffness as well as the problems with the angular deformities around the knee. I think you would agree with that. So
I go by the planning, and wherever the distal osteotomy has to be done, I do it there. The thing about over lengthening, actually, knee stiffness is not the only problem, but I think how much to over lengthen again is a
issue.
You're not sure. I mean, how much it will override, we can't predict. Yeah. So that problem is there.
Any questions from Dr. Mangal, sir?
Yeah, I have a question both for Ruta and Professor. That, whenever you have these damaged hips, etc., there is some remnant of the head remaining. Do you always excise the head, or do you sometimes do it without excising? If you do both, how do you decide which to excise, which not to excise?
Professor?
Yes, I usually don't excise the head, even in cases of neglected fractured neck femur, because perhaps the patient will need this head for a graft or something later on. I don't know, the patient is 14 years old or 15 years old. But I do have some problems with the long follow-up with the remnants of the hip. So the hip, whole head, cases of, some cases of hip dysplasia, you have very small fragments. And with long-term follow-up, I had a case after 11 years of the operation. and we had the operation at the young age, and we have to revise it. During revision, we removed this part. We think it's, with abduction and adduction, we have friction with the acetabulum. So in 2 cases, in about more than 150 cases, we have to remove part of the proximal femur because we think it's painful and can be more painful if you don't remove it. But I don't remove it as a routine.
If the hip is arthritic and stiff, I remove the head because I want the mobility as well. And in a stiff, painful arthritic hip, if you keep the head like that as it is, it might not relieve the pain. So I remove the head, I make the hip mobile, and then go for pelvic support.
And you do it in the same sitting or?
Same. I do it in the same sitting.
Dr. Mangal, I think I have one. Yeah, I have one answer. Once I show the presentation, I have a case like that. That would perhaps exactly answer your question. Maybe you got to wait for a while for that. Dr. Ravi, you wanted to.
My question to Dr. Gamal as well as to Ruta ma'am. Ma'am, you have shown your indications and Gamal sir have shown his indications of pelvic support osteotomy. I want to ask about the lower age group, just like 10 years, 9 years, 11 years, because these children have a lot of good remodeling potentials. Yeah. Then in that way, we can lose the pelvic support as well because of the remodeling as all that.
Yeah. My policy is not to do pelvic support before 10. So 10 to 12 years, because if you do it in young age, I had done it in, say, at the age of 8, and it remodeled in no time. The remodeling is so fast. So, it's very difficult to convince the patient to go through it again. So it was not, so I would rather wait for till 10 or 12 years.
Yeah, Dr. Ravi, I think I have the answer. Actually, the recommendation by the Ilizarov himself was that you don't do it before 14 years, at least 14 to 15 years. Yeah, so you don't do it. Because you don't do it because remodeling is tremendous. So you wouldn't have. At the end of the day, you will end up with a straighter femur. So there will be no pelvic support. That's not to do it before 15 years. So I had one of my patients, I made him wait till she reached around 16. So then I did pelvic support osteotomy.
So I have done it about 12.
Yeah, can I say something?
Please, sir. Please, sir.
Please, sir.
I don't disagree with the philosophy, but remember that if you have a 6-year-old boy and the patient have 5 previous operations, they removed almost all the muscles laterally, and you have migrating hip. Migrating hip, if you do an X-ray every year, you find the hip more. So this patient is liable to have pelvic obliquity, fixed pelvic obliquity. It's possible to have spinal deformity, possible to have secondary deformities. It's good. I agree with you. It's better to wait, but sometimes you have to take an action.
Of course, sir. Then you will take a decision on the case-to-case basis.
Yes, exactly. That's why I showed you a case. And this case, we had to revise it after 5 years, because exactly the body treated as a deformity, and within 5 years, we have a totally straight femur, as if we did nothing, and we did revision again. But in some cases, we cannot wait, because waiting is inviting for trouble. It's not a safe tactic or something. It's just to wait in such cases.
Thank you, sir.
Okay, I think we have. Ravi, you want to ask more?
Yeah, sir. One more, sir. And what about the indication in neuromuscular conditions, ma'am and sir, to sir also?
In
neuromuscular hip, sir. In neuromuscular hips.
Neuromuscular
condition.
Yeah. In neuromuscular hips, in polymyelitis, we do it no problem.
Yeah.
In CP, there are a lot of precautions, coming from the people doing in neuromuscular conditions. We did it in neuromuscular conditions, but the number of patients in this type of patient, the number of patients with polio is okay. There was no problem at all with polymyelitis, whether absent head and neck or neglected polio for such a long time, because it's very difficult even to do an arthroplasty. for cases with, poor muscular control. But with CP, I had only 2 cases, so I cannot judge from just 2 cases and improve. And the CP, you have different types of CP and different problems. So it's a bit difficult to get valid conclusion to advise other people to do it or not to do it.
Thank you, sir.
Thank you, sir. Thank you, sir. Dr. Mangal, sir, has the next presentation. Dr. Mangal, sir thinks that the rings are perhaps a little bulky, so he's shifting more towards unilateral fixators. So he'll be presenting his experience with the unilateral fixators, doing Ilizarov hip reconstruction by that.
Right. So Ruta has already covered the planning, and I think Altaaf is going to kind of revise that again. So I'm not going to spend time in exactly the planning part of it. As mentioned before, the proximal osteotomy is a pelvic support, and the distal is for lengthening and correcting the alignment. So the funda there is to get an extreme valgus. As mentioned earlier, some people do the proximal osteotomy with the plate. Some do everything with the fixator. So basically, you are taking away all available adduction from the hip, so the pelvis doesn't drop. We do a little bit of extension and internal rotation also. The distal osteotomy tends to be mid-diaphyseal. That's where the planning usually gets it. And this planning, I'll show you why it's critical. One of the cases where we sort of had a problem. And then in that deformed correction position, you can lengthen it and then realign. Right? So the maximum adduction view allows us to plan the angle as well as the level of osteotomy. And the principle is exactly the same. The only thing I do different is I try to use a unilateral fixator, right? So I'll just run through these because Ruta has already gone through this in detail. Ideally, as he mentioned, a young adult, if it's excessively short, then we know that the valgus will remodel. So the Ilizarov fixator has a lot of pros. It's very forgiving. Even if your angles are not right, you can continue to, infinitely adjust, as Professor Hosny pointed out. You can increase the valgus, you can change the varus valgus, even especially if you use a 6-axis device. But it tends to be a little inconvenient for the patient, especially if you have longer lengthening. A monolateral is a little more convenient possibly for the patient, but it is definitely unforgiving. You need very, very meticulous planning. Otherwise, you have trouble from that. So I'll show you one 10-year-old boy who had an awkward gait with neonatal sepsis and absent head and neck in the right hip. He had all the classical issues relating to, absent hip shortening, trochanteric overriding, flexion deformity at the hip, because of which he had this hyperlordosis. He was managing his Trendelenburg pretty well, but he wasn't able to stand on that affected side without leaning over, obviously. So just like spoken about earlier, that's his adduction view. So his valgus angle was 45 plus 15 degrees. We also do this single leg standing X-ray, but oftentimes because the patient cannot balance, you might get misled. So it's important to take both the maximum adduction view as well as the standing view. If both of them match, good. If not, then you need to go with the maximum adduction view. So basically, what we do is we mark out the pelvic line, which is the inferior end of the sacroiliac joint. We mark it out with a long K-wire kept across, and the hip is then maintained in maximum adduction. In this position, we put in the proximal pin so that it is parallel to the pelvic line, so that wire which you see, because ultimately that's going to remain in that position. The rest of the limb is going to come into abduction. So that's us holding that wire across on that. We mark it with a pen also so that we can see, and then put in this wire. Usually, especially if it's a small bone, I will prefer to put in a Ilizarov wire and then over drill on that with a cannulated drill bit, so that I'm sure of the central placement of my shank screw. So that's one. Then through the clamp, I put in the second pin, because the clamp guides that pin. The second set of pins are put in at the required, whatever calculated valgus angle we have calculated. Accordingly, they put. So this was, in this particular case, it was 60 degrees. Now for this, I use what I call in Hindi Sasta navigation. For Professor Hosny, that is cheap navigation. So I want the wire to go into the bone at a particular angle. So once I know those angles before. So usually what I do is I have tracing paper or OHP on which those angles are marked. So in this particular case, it was 57 degrees. This is a different patient, not the same one. But you have a line which lies on the cortex and another line which is 57. So if I've drilled correctly, I have this at the right angle. So I can relatively precisely get my pins at a particular angle, either to each other or to the cortex of the bone. The other thing you can use is make your angles beforehand out of cardboard or something like that. So here I've got a set of pins which are parallel to the knee joint. And I know that this set of pins has to go at 30 degrees to that. So once I hold one edge along the pin and then I drill the other one parallel to that, I know I am at 30 degrees. So the requirement for estimation or eyeballing gets reduced to a certain extent. Now, the one thing to remember is whenever you maximally adduct the limb, it always goes into some amount of external rotation, as you can see over here. This is straight, and you can see the wire which I had put in there. And when I take it maximally adducted over the other limb, it goes into some amount of external rotation. So to counter this external rotation, which is caused by maximum adduction, we build in a certain amount of internal rotation. Usually about 10 to 15 degrees is what is required. So the second set of pins, when you look at it from the top, it's not only 60 degrees to each other, but when you look at it from the foot end, you can see I've put in the proximal pin, I've put in a goniometer, and I'm passing a wire at a different angle. So once the osteotomy is done and both these pins come in the same plane, essentially I have created X amount of internal rotation. So one pin above, one pin below to mark that rotation. And the osteotomy is exactly as we talked about. And the between those two sets of pins that we have done. So once the osteotomy is done, we can do a valgus angulation and keep that connected by a rail. So what has happened now is the patient has gone into excessive abduction or valgus. So now we need to do this distal osteotomy, and there is also an extension at the osteotomy. I'll show you how we manage that in a slide that comes in. So here, with more experience, now I'm able to put in all of the pins before I do the osteotomy. So here you will see the proximal set of pins are internally rotated and the distal set of pins are externally rotated relative to each other. So once that osteotomy is done between those two pins, it will create internal rotation of the distal fragment. If you look at this set of pins, they are diverging from each other. That is, when they are closed, they will create valgus. And if you look at the middle set of pins and the distal set of pins, you will find that they are diverging, or the ends are closer to each other. So when you get them parallel on a rail, that will create the amount of varus that you need. So they are put in at specific angles. Also, notice that the top set of pins is kind of parallel to the bed, and the middle set of pins is slightly tilted backwards. So now when both of, looking at it from the side, when both of them come into the same plane, there is going to be a certain element of extension that comes in. This, of course, is limited in case of a unilateral fixator. It's limited by the size of the bone, because depending on the diameter, you can't angulate it too much. With an Ilizarov, on the other hand, you can angulate it, exactly how much you want. So this is one of the downsides, that the amount of extension you can cause is relatively limited. So the distal set of pins are at that diverging angle, as I told you. And once you do the osteotomy and get both the pins parallel, that varus is corrected. Now, this is another difference of how it is done relative to an Ilizarov. When you do it with an Ilizarov, generally, you don't put in the varus initially, you just distract. And at the end, you put in a hinge and correct that thing. But because this is a unilateral fixator which goes on a rail, we have to create this varus right away. We wait, instead of 7 days, we wait for 10 to 15 days before we start distraction. And initially, we do the distraction at a gradual rate. And once this is done, you check your mechanical axis. That is, from the center of what used to be the acetabulum to the ankle, and confirm that it is center or slightly medial to the center of the knee. So now here we've got the whole thing set up. So here's his post-operative X-rays. That's 50 millimeters of distraction. At this point, he needs 20 millimeters more because the pelvis is still not level. So rather than just the limb length discrepancy, I also look for a level pelvis. That's 6 months post-operative. His proximal osteotomy has healed well. The regenerate has still not solidified well enough. But this guy was he was an Indian patient in the Middle East. So one thing is, you can continue with the fixator, but something else that I tend, especially when there is a long lengthening, is to consider the use of internal fixation. So we take off the fixator and put in a locking plate internally as an internal splint. So that's him at 11 months post-op, healed well, limb lengths are equal. If you see his axis, that is from the ankle through the center of the knee, it hits the around the acetabulum. That's him walking at 2 years. He still has a little bit of lordosis, I think, which is because we are not able to correct that extension as much as one would like. But importantly, this is a single leg stance X-ray. There is no drop in the pelvis. So his opposite pelvis is higher than this one, which means that we have succeeded in taking away all his adduction. So I think Ilizarov hip reconstruction, no question, as Professor Hosny said. I think also that this is a one-time procedure. This is not something to buy time for a future total hip. And the biggest advantage I think it has over conventional PSO is that you restore the length and you are normalizing the axis. So there is no knee arthritis in the future. One of its biggest pitfalls of doing it with a unilateral fixator is that the planning is critical. And as Altaaf pointed out, that the osteotomy tends to be a little more towards the mid-diaphyseal region. For any reason, if you don't do it correctly, so what you see in red over there is the plan that we made, and what the underlying X-ray is what we did on table, and that was wrong. You know, we should have been more careful in terms of the location. With this, there tends to be a little more knee stiffness in the immediate postoperative period, but if you release the soft tissues adequately, do an excision of the iliotibial tract at the just above the knee, then there is no real problem. In long lengthenings, the consolidation does tend to be a little bit delayed, which I get around by giving them the option of using an internal splint. Now, whether an Ilizarov hip reconstruction is a long-term procedure or not, this is one of the first patients that I had done an Ilizarov hip reconstruction, and she came back to me for pain in the right knee. She was, I think, about 19 or so when we had done it. You can see that she's able to stand reasonably well, a little bit of lean, but in terms of gait, she's got no limp, no lurch, and at 20 years, she's got no problems with the hip. So that's how I do it with a unilateral. Happy to answer any questions.
Thank you, Dr. Mangal. As usual, excellent presentation from your side. But I think, like you said, that you wanted to make more patient comfortable, but I don't think the surgeon would be that comfortable to deal with it to begin with. Especially for the beginners, it will be really very difficult to understand the tricks of putting in an external fixator in exact angles and then manage, because the rail is fixed. So any kind of this alteration in the anterior posterior direction may not be dealt well with the beginners. So they will have to really get trained for that using a unilateral fixator. While on the other side, the Ilizarov is definitely forgiving, and it will allow some kind of an adjustment post-operatively. I think Dr. Mangal will agree with that. And second thing, what you, sir, pointed out regarding that angulation in the middle, and then the mechanical axis was going away. I also experienced it many a times, but many a times what I found actually was the problem with the abductors that were tethered. So once we tried actually to adduct them, it was the pelvis which was tilting. And once we created a valgus, like in my forearm, once we created the valgus, so since the abductors didn't get released, so it remained in that position while we tried to get the axis back from the middle of it. I'll explain it once I show my cases. I think that was the reason for getting the problem. We need to discuss that, how we need to deal with the abductors in such situations. Do we have any questions from, or else I would go with my presentation and then we would have enough time to discuss at the end.
Altaaf sir, you can go ahead with your presentation. Thereafter.
Yes. Yeah, there's no question. You can go ahead, sir.
So I'll just, since I didn't know what your other faculty would be presenting, I had this idea that at least I would be summarizing what we had done. So I thought that I would be just summarizing the principles and long-term results of Ilizarov hip reconstruction. Then to revise it, we have three components. That you have a pelvic support osteotomy, then you have the lengthening realignment osteotomy, and then addressing the gait by improving hip biomechanics. So addressing the gait issues, it's actually how would you abolish the Trendelenburg gait and how would you realign the mechanical axis. So if we took an example, the site of first osteotomy has to be at the area where it touches the ischial tuberosity. This example, so you do one leg standing stance view on the affected limb. You see the pelvis is dropping on the other side. Then you got making in angles like Dr. Mangal showed and Dr. Ruta showed. This is the angle A. Then you would like to add 15 degrees to this to create the actual pelvic support. That's how it is done. And second, this is already explained how we assess the second osteotomy, like it's shown here. Then the second osteotomy, and finally you got the support, you got the length, and you got the exact mechanical axis. So what could it be applied to, like Professor Hosny showed that, and trauma is not uncommon. So neglected trauma, like in their country, our country also has neglected trauma. So you have neglected hip dislocations. Post-septic sequelae make the majority of these patients. And then sometimes there are many failed surgeries, especially the osteotomies. And one more important thing is tuberculosis, like Dr. Ruta showed earlier. So going with this example of a 16-year girl who had a fractured neck of femur presented to us at 1 year. And this is how the trochanter has gone up and the head is still there. So like this is some answer to Dr. Mangal. So she had 4 centimeters of shortening. This is the pelvic support osteotomy, and this is the distal lengthening and vericizing osteotomy. This is our frame. So this is the pre-op, and then we have nicely restored everything. So if we concentrate, the abductors are now tightened if you compare with this. Abductors are stretched now if you compare with the pre-op one. Then you have a good pelvic support, you have head and valgus, and then vericization. And then finally, the hips or trochanters are at level, and you have a good, nice mechanical axis. And more importantly, our length is equalized, and this is what our patients need. They can't have restricted range of motion. They love to see, have extreme degrees of motion around hip. And importantly, this is the Trendelenburg. This is the affected limb. And this is the normal limb. So this is a functional. Then her gait is good. She has a brisk gait. Actually, I had a video of now 15 years that I couldn't just upload it. She has the same function this time. She's absolutely pain-free and doing well. Then, not uncommon in our setup, you have a neglected dislocation. She has associated 6 centimeters of shortening. Again, same set of planning. Then you have the support. You have a good chunk of lengthening in between, and we have been able to restore the mechanical axis. This is like Dr. Mangal was asking that, what would you do if you have still the remnants of this hip? So we didn't do anything with this, but like I said in earlier discussion that this is many a times a concern. This was my earlier days. I didn't realize that many a times it does not come like you have tried to abduct. It is actually a fallacy that you see the patient getting abduction, this adduction at the hip while the pelvis is actually moving. That's why once you create the valgus, that valgus then remains rather than getting fully vericized. This is what I meant to see. Actually, this has not allowed it to move. And then you got the length, you got everything was done. Everything was achieved. The length was equalized. Our function is normal. And not looking at the X-ray, but looking at the function, one can understand how beautiful function is at 13 years post-surgery. This is on the other side, not that effective, but she doesn't have a drop, but her gait is brisk and she's pain-free I last saw her at 15 years, since this was an earlier presentation. This was a 32 years old engineer. Again, he had a post-septic sequelae and 7 centimeters of short. I don't know how beautiful an orthoplasty would be here in such a situation where you have so much of a shortening. And if we go through Campbell, they say such situations that where you have damaged hips, orthoplasty is done nicely, but Then the quote says below, the footnote says that the hip was, orthoplasty was done, the limb remained short by 4 centimeters, and the abductor function was poor. So we don't actually want, like I would agree with Professor Hosny, that we don't want only a cosmetic surgery, rather than we would like to have a functional hip. So same planning. So this is like Professor Hosny said, that if you have this higher up the osteotomies around the acetabulum, one of the methods by Ilizarov himself. So this is the proximal and this is the distal one. So my idea is like the others would say that they would lengthen first and then would vericise. But what I do, that my frames usually have a hinge built in from the beginning. So I distract in the differential way so that I get a gradual vericization simultaneously with lengthening. So I don't have to do it at the end of the day, but the this regenerate angulates simultaneously once we are getting the length. This is the limb equalized and nicely able to have extreme degrees of hip motion. This is the pre-op as a short limb as well as a lurch. And this is post-op. There's improvement of the gait, though the gait is not totally, the Trandlenberg is not totally abolished, but he has a functional hip and extra limb length equalization at 10 years of follow. Another girl, ganoposeptic sequelae. Again, you see that you have the pelvic support, the vericizing realignment osteotomy, and this is the function and final axis. Initial gait, short limb gait, as well as a leg. And this is at the 3rd year of surgery. Markedly decreased limb and Trandlenberg. This is very effective here. So like Dr. Ruta said, that we have this application in tuberculosis ankylosis. So what I would do, I rather do, I convert the painful fibrous ankylosis to painless but unstable hip by girdle stone excision. What I differ from, as Dr. Ruta said, that she would be doing it the same thing, but I tend to do it at a later stage, put in the traction and make it, convert it to an unstable, painless hip. Then at the second stage, I would go with the reconstruction of the unstable hip with Ilizarov hip reconstruction. So this is tuberculosis fibrous ankylosis. This is after girdle stone. Then these are the osteotomies. This is the lengthening osteotomy. This is of final hip. You have the support in the acetabulum right up there. And then this is the axis. We have corrected the axis as well. And most importantly, this is the function. Again, 35 years old lady with tuberculosis. This was done long back. Maybe nowadays people might go with orthoplasty. They might prefer it. So this is the osteotomy, and this is 13 years post-surgery. So like Professor Gamal said, that they don't have any complaints. This patient again does. But if we go with the radiology, perhaps, I don't know till when she will remain pain-free. But as of now, after 13 years, she's comfortably walking and she has no pain. This is how her gait is, how smooth gait she has at 13 years post-surgery. So we published our initial results in 2015. So I had, like Professor Gamal said, that we tend to have many cases. So initially I had in these initial first 10 years, I had around 20, 23 patients. So we presented that and we published it. And these are important things. We had a healing index of 1.54 months per centimeter, and mean external fixation time was 8 months. And the Harris hip score improved from 56 to 83. So now I am having a real look of these patients. I have around 10 patients who have a longer follow of more than 10 years. And all are stable and function. One patient only with tuberculosis hip complained of pain. There is one patient had mild restriction of motion, and none of the patients complained of any difficulty that would demand intervention. Thank you very much. I think I'll stop sharing.
Thank you, sir.
And then
I have stopped your sharing, sir. Altaf, sir.
okay, thank you. Thank you. So, sir, at the end of the presentations, we have, like I have certain comments or other explanations which I would need to have from Professor Gamal as well as the senior colleagues and senior friends. Like sir, I showed my case. One of my cases, you have septic sequelae. Their abductors tend to be tethered, and once we try to have an abduction, it doesn't move. And then if in such a situation, we try to do an pelvic support osteotomy, we do get it like this, but then the limb tends to remain in valgus. We get it back and the varus tends to be more, like I showed in one of my cases. Though the function at the end of the day was excellent, but I would always prefer, do we need to address those abductors? Do we need to do kind of a super hip in such patients?
You know,
Prof, you go first. Yeah.
I don't know, but I've done a few cases. The way you do it, there was no real support. You know, with the follow-up.
In that case, yeah, that's what I'm saying.
But clinically, there was no problem at all. The patient didn't complain, and there was improvement. So I was not planning to do anything, and the patient didn't ask for anything till now. You know, just with such a long follow-up. So I don't know. This is not the final answer, because we still, the patients are young, and perhaps after 10 or 20 years, you will ask for something more. But usually the frightening thing, the patient will need an arthroplasty afterwards. What he's going to do is going to be real difficult or something. And this is the usual question by the people doing arthroplasty when you present in a meeting or something. All of them have one question. What's going to happen if the patient needs pelvic support osteotomy? I always tell them that this is an operation for good. You don't need an arthroplasty. But I've seen, I think Professor Hefty from Switzerland, he told me that he did 2 cases after hip arthroplasty in Switzerland, and there was no problem. He just corrected the osteotomies and did the implant, and there was no problem at all.
I agree. I agree with what he said, that it's a long-term operation, and in the occasional patient where you think that they might want to have an arthroplasty, a skilled arthroplasty surgeon just has to do the osteotomy and undo the valgus that we have created. Anyways, when it's a high riding hip, they oftentimes need to shorten the femur, right, to bring that trochanter down. So as part of that, and like a revision hip with a long stem and stuff. Now, in relation to what you asked, that is actually a failure of planning, because like we say, adduction X-ray. When you do the adduction X-ray, you should have the pelvis in view.
That's right. That's what I say.
So the maximum adduction that is possible is measured on the X-ray. So we don't do offhand, 60 degrees in every patient. But if like your patient had 15 degrees, then the amount of valgus for that patient would have been 30 degrees. That's number one. Number two is, this brings into question the terminology. Is a pelvic support osteotomy really supporting the pelvis, or is it tightening up the abductors and taking up all the adduction? I think it is more of the former. That is, you're tightening up all the soft tissues and the pelvis cannot drop anymore. That's number one. Number two is, in that straight position, if you lengthen, the trochanter is just going to go further up. Whereas when you do the abduction, it is going to be pushed against the pelvis. And that's one of the reasons why we say that, you lengthen in that abducted position and then gradually correct it. But
Because
as I said, my experience,
yeah.
so then it won't, the force is towards the pelvis. It's not vertical.
So actually,
but as you have found, I also correct the varus, and as long as I have a decent degree of valgus above, it does not cause a further upriding of the
yes, that's absolutely right. I think it's basically that it's preventing the telescoping. The angle we create, it's preventing telescoping rather than giving really a good support only.
Yeah,
that's the main thing. So
because one good thing, especially in your long-term patient, we can't do a CT scan in a standing position, so you can't actually make out what is happening in 3D. I mean, the ischium is here, and if your shaft is anteriorly there, really speaking, there is no support. There, it makes more sense to what Dr. Hosny was saying, that you do a higher osteotomy. So there, it's likely to abut somewhere along the acetabulum, etc.
That has only one
the low ones that we do.
Yes, that has the only one concern, that once you are doing it with the low ones have tendency that the fragment that we have created, it will be away from the stapulum, though it will be creating a mechanical axis, but at the same time, there will be no interaction with the joints. So less chances of having kind of osteoarthritic pain there. While as once the one I showed you have in the STMA, it's a brilliant support. The lesser troch has gone within the acetabular. And what would be the take that? Would they finally sometimes go into osteoarthritis? But if we go by Professor Gamal, then
the question is what causes the pain of osteoarthritis?
The cartilage.
There is no cartilage over there.
No.
There is a good thick pad of fibrous tissue. So the sclerosis which you see on the X-ray is not necessarily arthritis. It could be just a reflection of the weight bearing.
Right, sir. In such a situation, that such patients would go another 20 years. Why should they have any issue?
I think so.
So the take would be like, sir, if we all, like the guys who are doing pelvic support osteotomy, if we combine our groups together and the number of cases, that will make, I think, a real good study. Because we have all different kind of things. So the volume will increase. Like I agree with Professor Gamal, that the author, Professor Pally, who already had 7 or 8 cases, and then like the rest of the world has too many of them. Perhaps that would give a long term. So if we collaborate, if we have, Professor Gamal has around 150 cases. So if we join together, this is going to make a big series, and this will be real good information to the rest of the world. So any other questions? Do we have any other questions?
No questions. But I mean, I think the bottom line is that all of us, the cases that we've shown, I think there's hardly any doubt. There should hardly be any doubt that this is a great procedure, especially for our settings where you need patients to have, mobility of the hip as well as stability. Now, our patients, the stability may not be absolutely perfect in the sense of as stable as a THR, for example, but essentially they are stable enough. And the gain that they have in the mobility is very, very important for our situation.
Yes, and they don't have any threats of having infections, loosenings, revisions.
Yeah.
There are certainly, and especially in our setup, like the girl I showed with the DDH who has got neglected, and she got all the length. She's functional and she has full support. What else does one need at 16 years? And then if your axis is right, your this gait is restored, I don't think we have any issues. And regarding this, sir, your external fixators, I have only one concern. Perhaps somehow I think the regen rate is not that great as you see with the refixators, because of the axial loading. rather than you have in. I used in TBS. We see those guys who have used in. Somehow the regenerate tends to be little because it's quite a rigid assembly than an Ilizarov.
No, I showed you this particular case because I had a good bunch
Not
of
that you had
X-rays and all.
some issues,
but otherwise, generally it's not so much of a problem. It could be, but I don't think in particular it's not a major issue. In terms of lengthening, when we do lengthenings with unilateral fixators, there's no specifically downside in terms of the regenerate healing. Yes, I grant you that it's a much more precise application. I grant you that there is no adjustability, but regenerate formation is not a big issue. Let's ask Dr. Gupta. Were you a skeptic or were you a believer in terms of Ilizarov hip reconstruction?
Sir, Ilizarov hip reconstruction is a very good thing, sir. Our patient needs mobility.
No. My question is, before you heard all of this, were you a skeptic or were you already a believer?
Sorry, sir.
Dr. Mangal
Before
is
you
asking,
heard all of us talk, did you believe that IHR can give such good results? That's what I'm trying to ask.
No, sir.
You've gone mute again. You've gone mute.
Dr. Govind, please unmute yourself.
Sir, in fact, I am seeing first time such a wide spread of indication of Ilizarov reconstruction of the hip. Truly, I am saying, and first time I am believing that the function of the patient, which our patient needed, is very much given by this Ilizarov reconstruction methods.
Yeah, that's exactly what I wanted. That when you just hear it, one wonders, these people must be just talking. It's not real. How can they have such a stable hip when there is no head? But I think all of us have shown cases where there is good stability, a good gait, and good movement of the hip. Shamsul, you want to add something? Shamsul is there.
By the time Shamsul unmutes himself, sir, I have one important thing that all of us have spoken about the frontal alignment. And you must have also, like Professor Gamal, I would also like to know, do you have any sagittal plane deformity in the regenerate? Once you go on lengthening, you have large lengthenings. In frontal plane, everything is going right. But in the sagittal plane, it tends to go into flexion. How do you address that?
Usually we do extension osteotomy in the upper part. And
that's right, but by the flexor forces, the flexion forces at the hip, they tend to then go into flexion and the regenerate tends to bend, kind of a curve.
And I always change the frame. I have the guys working with me. So it's almost every week we change the frame. That means for the length, we see how the patient is walking in the last stage. And perhaps we increase the length because there is some sort of limping. Also,
no. So my question is not that. So my question is that we have, like you see, the regenerate is going nicely in the frontal plane. The lengthening area in frontal plane. You see in the AP plane, everything is fine. We are trying to restore the axis in the frontal plane. But then because of the forces at the hip, you are getting flexion at the hip. And since the regenerate is going away, so the stability is going away, your fixation is away. So it tends to curve in the sagittal plane. That's my question, sir.
This is true. It's almost in each case, if you have lengthening for more than 5 centimeters, you have forward flexion of the regenerate, and we correct it by putting a distractor behind and the posterior part and the hinges. And usually we correct it. But almost in most of the cases, we have the anterior or forward flexion deformity of the regenerate.
Because your fixation, like whether you do it with external fixators, unilateral planar fixators, or you do with Ilizarov, your fixation is from the lateral side. So that's going to take care of the femur on the lateral side, but it will not correct it. It tends to allow it to go in this position.
Exactly.
So do you have some kind of having a biplanar fixation?
Yes, but we put it anterolateral and posterolateral. you know,
Yeah.
and now I have more fixation than before. So I put, at least in each level, I put 4 half pins if it's half pins only. And sometimes I put wires too to prevent the deformity. But whatever you do, you always have some sort of flexion deformity of the regenerate, and usually we correct it during the follow-up. 1 millimeter per day, exactly like lengthening. There's no problem with that.
Right,
With the
sir.
circular fixation.
I don't get that flexion, and it's not because I'm a better surgeon than you. It's just that the rail is such a solid device that it doesn't allow, and I've got
It won't allow.
in that
It allows
plane.
it. Yes.
Yeah, I've got 3 pins in that plane. It doesn't allow that flexion to occur.
It won't allow. It
On the
won't
other
allow.
hand, I wouldn't worry too much if you're using an Ilizarov, whatever deformity kind of comes up. You know, Ilizarov, usually you have just one ring,
Exactly.
and you may have some fixation above and below. So that will tend to be a little bit unstable. But because you have the Ilizarov, you can play with it, you know, as you like. So I think that's not really
It is
a
not
problem.
Finally, at the end of the day, sir, it doesn't give you any trouble. But for the kind of actual osmosis of regenerate.
I would say that the base reason there is more instability rather than anything severe in the hip. Because if I'm doing the same thing that you are doing, the hips are stiff or whatever, and I don't really get that procurvatum, then it boils down to the stability.
Right.
Actually, procurvatum deformity in lengthening of femur through the distal corticotomy is very common. So you always, at the end of the day, if it is there, add hinges and correct it. So
That's about like Dr. Ruta said, the distal osteotomy. I'm saying that in the proximal also, you have, because there are strong flexors from the proximal fragment. So that they
posterior, your posterior muscles are very thick.
Yes, yeah. So do we have you, Dr. Shamsul? Do we have any questions from the viewers?
I'm audible, sir.
Not yet.
Yes.
Yes, you are.
Sir, my question, just one question. If you do in a young children like of 10 years or 12 years, in how many cases have you seen of revision? None, sir.
Revision, you mean to say just revision?
What the ratio of revision surgery? Yeah.
Because of
Or remodeling.
Remodeling is bound to happen.
What is the ratio, sir, you have seen?
Your question is to Professor Gamal, sir.
Yes.
Yes, sir.
He asked about the revisions.
Yeah. In case of
I had in my life. It's 4 cases of revisions. One of them was done elsewhere, and the 3 of them from after I have the first operation at the young age, and one of them I have to remove the proximal fragment because there was pain. I don't take care of the X-ray picture, but if there is pain, we remove this the proximal fragment, because sometimes it's the upper femur is misshapen. You have triangular part and you have strange shape, and the patient was in pain, so we removed the proximal fragment before the pelvic support. So I had the experience only in 4 cases, and they went well. There was no problem.
So I think the short answer is a very small number. Generally, I've just treated 2 patients who are less than 12 years. One was the one I showed you. He's now about 4 years post-op. He hasn't had anything. But that is the general advice that is given, that, if you're doing it in younger patients, warn them that there may be remodeling and you may need to redo it. But I don't think it happens that frequently.
I think, sir, we have had excellent discussions, excellent presentations in today's webinar. And I think the viewers must have got an impression that this is such a wonderful operation. And then if we together join our experience, and there are many people who believe in the Ilizarov philosophy, that this is such a wonderful procedure for dealing with damaged hips of diverse etiologies. I think with this note, I would like to thank Professor Gamal. It was really an honor that you accepted our invitation and you presented your experience with us. And I would like to thank Professor Dr. Mangal Parihar, Dr. Ruta Kulkarni, our president of the ASAMI, Dr. Ravi and Dr. Shamsul, two energetic guys, always there to help, always there to arrange, and always there to have things made very easy for us. We have had Dr. Govind with us throughout the meeting, and it has been nice, like Mangal pointed out, that he would be a neutral judge to judge between the two procedures. Perhaps he will be the facilitator of Ilizarov hip reconstruction rather than orthoplasty. I again like to thank our president, Dr. Shivashankar, for giving us opportunity to deal with this Ilizarov subcommittee, and our secretary, Dr. Naveen Thakkar. So with all this note, we thank you again. Thank you, sir. Thank you, everybody. And good night. Good night.
Thank you.
Thank you, Dr. Altaaf.
Good night, sir.
Thank you, Professor Hosny.
Bye-bye.
Thank you very much.
Thank you, sir.